Good. So thank you again to Project Echo for having me back. I really appreciate this subject and talking with all of you and connecting. So I appreciate the introduction as well, Rachel. I do not have any conflicts to declare. So today we're going to talk a little bit more about additional uses for prenatal cell-free DNA screening, considerations when choosing a test, and then the limitations of this technology. For those of you who might not have been able to join during the first session, I did wanted to provide just a little bit of an overview about this technology and its use. So non-invasive prenatal screening, or the terminology that we're trying to adopt across our practices, is cell-free DNA screening. This technology is the most sensitive and specific screening test related to the common aneuploidies. So specifically trisomies 13, 18, 21. It does have the lowest false positive rate of any screening test used to date. It can also screen for fetal sex aneuploidies. It can be done as early as 9 or 10 weeks, depending on the rendering laboratory. It is not diagnostic, and it is dependent upon the amount of placental DNA circulating in the maternal bloodstream. And as a reminder, we call that the fetal fraction. So that fetal fraction does have to be at a threshold for analysis to occur. Otherwise, you get an uninformative or a low fetal fraction result. This technology is recommended by multiple societies. So the American College of Obstetrics and Gynecology recommend all pregnant women, regardless of their risk, should be offered this screening technology. International Society of Prenatal Diagnosis also endorses the use of this technology. And the American College of Medical Genetics and Genomics also recommends all women be informed of this technology as the most sensitive screening option available. Most recently, the Society for Maternal Fetal Medicine just released an update to their guidelines, also further endorsing this use, along with a couple of other recommendations related to the use of this in twin pregnancies, and the use of this related to sex chromosome abnormalities and microdeletions. So I will, if I can remember as I move through, I'll mention some of that. So this is a visual aid that I share with my patients to demonstrate exactly what we are evaluating in the maternal bloodstream. So I highlight to our patients that we are not looking at the baby's DNA. We're not doing that. We know that when sperm fertilizes the egg and creates that embryo, that ball of cells does become both the placenta and the fetus. So ideally, we expect the placenta and the fetus to match from a genetics perspective, but we know that that is not always true. However, that is an assumption that is made with this technology. So because of the cell turnover and the programmed cell death, that the placental cells, specifically we refer to those as the trophoblasts, as those cells are dividing and then dying, they're releasing the contents of their nucleus, which are the chromosomes. And fragments of these chromosomes are therefore circulating in the maternal bloodstream. And we are able to then quantify the amount of that chromosome material that is coming from the placenta and mom's blood. And we can then derive if there is extra chromosome material related to chromosomes 21, 13, 18, or X and Y. That technology has largely been used, and the recommendations that I just mentioned to you are for those group of 5 chromosomes. There are additional applications of the screening test, which is what I'm going to focus on in today's talk. So moving forward, here we know that about 3% of pregnancies are affected with some sort of birth defect or congenital anomaly, and 10 to 15% of those are chromosomal in origin. When I say chromosomal in origin, I'm referring to the fact that there could be an extra chromosome, a missing chromosome, a rearrangement of chromosomes, or for the purpose of today's talk, it could also mean there could be something called a copy number variant. A copy number variant, you can think of that as a deletion or a duplication within the chromosome. And if we go back to thinking about our DNA and how it's bundled into our chromosomes, we know that a deletion of a piece of a chromosome is going to include valuable genetic instructions or information. So if there's a deletion or a duplication present in a chromosome, then that means a developing fetus is going to have either missing or extra information, which of course can impact the function and development of that baby. Various laboratories do offer copy number variant analysis and expanded aneuploidy screening. Just to define what I mean here once more, copy number variants, meaning the ability to detect deletions or duplications within a chromosome, and then expanded aneuploidy would mean looking not only at the common 5, 13, 18, 21, X and Y, but opening it up to look at all 23 pairs of chromosomes. And so this is not a recommended option to be offered to all women in pregnancy. And largely that's because it's really difficult to estimate the sensitivity and specificity of the technology, and then also what that would mean to a patient if it were to be positive. So in other words, the positive predictive value is not a reliable statistic because of the low incidence and how rare these genetic changes are. So what we say, and what SMFM just recently said in their update, is that if you have a patient who is concerned for a copy number variant or a deletion or duplication of a chromosome, they should ideally be offered a chromosomal microarray. And that type of technology is done on a CVS sample or an amnio sample in a pregnancy. And that's what we would consider a diagnostic test, the ability to actually scan those chromosomes and pick up those deletions or duplications of material. Now, I have here just an example of what I mean by deletion or duplication. I think that this slide is self-explanatory, but I'm going to kind of move through it anyway. If you're looking at the middle set of chromosomes, this pair of chromosomes has segments on the long arm of A, B, C, and D. You can see that on the left side, you have a deletion of that C segment. And on the right side, you have a duplication of that C segment. So that extra or missing genetic material can be screened for if it is big enough using the cell-free DNA technology. There's one particular lab, LabCorp has a test called Maternity Genome that is able to do this. So this technology is able to open up and look at all 23 chromosomes. So that can tell us about extra or missing whole chromosomes outside, again, of 13, 18, 21, X and Y. So it can look at 1 through 23. It can then screen for those deletions or those duplications if they are big enough. So we say that those copy number variants, ideally, their average is the ability to detect greater than 7 million base pairs. That's quite a large deletion or duplication of material. If you put that into perspective, a lot of times, if you're thinking about a gene, for example, a gene itself might only be, a few kilobases, a few thousand base pairs, whereas something that is a million base pairs, that might include multiple genes in that area. So it does have to be quite large in order for the technology to be able to screen for it. But I will say that their ability to get to a higher resolution has certainly improved over the years. A reminder again that this screening test is not diagnostic. It's still looking at that placental DNA that's being retrieved from the maternal sample. And one thing too that is helpful from this type of test is that there is a reflex option, meaning if you started with a Maternity 21, which some of you may be familiar with, that's LabCorp's basic routine cell-free DNA screen. If you start with that and a patient then say has ultrasound findings later in the pregnancy, maybe there's not enough fluid to do an amniocentesis, or maybe the patient is just really not comfortable with an invasive procedure. You can then reflex to maternity genome, usually without providing a second sample, which can be helpful. So considerations for the use of this technology would be if you have some non-specific findings on an ultrasound, or for a patient who does not want to undergo prenatal diagnosis. If you have a translocation in a parent, so if your patient has a rearrangement of their chromosomes, you might be familiar with this as it applies to recurrent pregnancy loss. A lot of times, if a patient comes in for having 2 or 3 or more first trimester losses, one of the routine tests that we do is to look at that person's chromosomes. And when we do that, we're looking to see, okay, does this person have a rearrangement of their chromosome material? Not that they're missing the material, it's just that their genetic information is not in the correct place. And of course, when they go on to pass that information down, whether it's in the egg or the sperm, that information can then get lost as it gets passed to the fetus. And so if that information is lost, that results in a deletion or duplication of material that could theoretically be picked up by this type of screening if it's big enough. And then sometimes we have patients who are really highly anxious, maybe because they have had a child who had anomalies in a prior pregnancy, or maybe they, have been that statistic before where they have a child with a chromosome condition, and they really just want the most extensive, non-invasive screening option. So we do offer that in those cases. So I'm going to move right into an example of this to the first case. This patient is a G3P1011. She has a history of a brother who died of an unbalanced translocation at 7 months old. He died of pulmonic stenosis that was not diagnosed prenatally. Upon learning this history, a chromosome analysis was ordered on the patient to see if she could be a carrier of the balanced translocation that affected her brother in an unbalanced way. So at this point in her pregnancy, she is about 28 weeks pregnant. This lab result that you see here on the screen is a karyotype. So this was counting cells. So they received a blood sample from this patient, and they then were able to look at the cells at a specific phase of cell division in order to see the chromosomes and to see, were there any pieces of chromosomes that were swapped or not where they should be.
So Jessica, I realized we didn't give a symbol for like how you'll know I'm going to ask a question. So I'll just say Jessica. Is that good?
I was thinking that maybe we could do questions after each case.
After the case. Okay.
Yeah.
So after each case, then a question.
Yeah.
Got it.
Yeah. So with this particular result, this patient had a translocation existing between chromosome 9 and 20. So if we look at this here, she has 46 chromosomes. So she has the proper amount of information. She is not missing information, which is why she's unaffected. She is a female, so she has 2 X chromosomes. And then this little T signifies to us that there is a translocation or a swap of material between chromosome 9 and chromosome 20. And these numbers indicate the specific breakpoints. So then we knew at this point, she does have a balanced translocation and is then at risk of having a child with an unbalanced form, similar to her history of a brother who died. So we offered her a chromosomal microarray, which is that diagnostic test that would be performed on an amniocentesis to detect that unbalanced translocation. We talked about how this is a definitive option, meaning it's going to confirm beyond a doubt that this is where those breakpoints are. This is the genetic material included that's missing or extra. And then we also offered her the option for the cell-free DNA maternity genome. Upon calculation of the translocation, we felt that the deletion or duplication would be large enough to be detected by this technology. However, this technology was not going to confirm specific breakpoints or the specific genes or instructions that were present. So she elected to move forward with the maternity genome. She felt that she didn't want to do an amnio right at that point because she felt if this had been negative, she was not going to proceed with a diagnostic test. So unfortunately, it did come back come back that the baby does have the same unbalanced translocation as her brother did. So this result is an example of the maternity genome where it's telling us there was a loss of chromosome 20 material, so a deletion, and a gain of chromosome 9 or a duplication. So this was consistent with the potential outcomes that we did present to the patient based on her balanced translocation. However, we were still uncertain of the specific breakpoints and therefore what genes were included in those regions. As an aside, that's important for us for prognosis. If we can identify what genes are included, we can go to the literature and say, okay, what does this look like in other affected individuals? Have these microdeletion syndromes been explained or investigated in other families? So she did opt for an amniocentesis at that point to confirm this diagnosis, at which case it did confirm baby to have that same deletion and duplication. And then we were able to look within the regions to identify that children who have this or expected to have intellectual disability, variation of congenital abnormalities, several craniofacial findings and dysmorphic features, and then epilepsy, as well as one paper suggested the pulmonic stenosis or a congenital cardiac anomaly. So takeaways from this case included that this patient was a good fit for this non-invasive option due to the predicted large unbalanced rearrangement. She also now knows that this technology can screen for her future pregnancies. So she could do this test as early as 9 or 10 weeks in a future pregnancy. Chromosomal microarray then also allowed for confirmation of those breakpoints and the included genetic material, and we were able to take that information and provide it to a multidisciplinary team in order to properly counsel her ahead of delivery and make sure that we had all of the right teammates involved in the care of that baby. So I think now would be a good time that I'd welcome questions.
So again, how this is going to work is please use the chat. Actually, it would be best if you just chat to everyone because I can see it and your question will be read without your name identified so that we can have this recorded for people who are not here today just to hear questions. And so that's why we won't identify who's asking. The first question I have is, does insurance cover maternity genome?
That's a really good question. So insurance is going to cover the kind of the common trisomies. And so the way that the lab companies are billing for this technology is that they are receiving the allowed payment for the common trisomies. The extra data that they're getting is a part of their platform, so it doesn't cost the lab more to uncover some of this material. So we are seeing it being covered almost in the same manner that a traditional routine cell-free DNA screen is being covered.
Okay. I'm just taking a pause to see if there are more questions at this time. We need to give some think time.
I'm also happy to clarify anything that may have been unclear with
yes.
the technology.
Clarifying questions as well. I suppose what could be okay is folks from our hub team. If you have questions, I think it's okay for you to unmute from our hub team. I think it's okay to move on to the next
Okay, very
phase.
good.
And if folks have questions, come to them as Jessica is presenting, just start to flow into me on the chat.
So I wanted to review that expanded cell-free DNA has really the same limitations as our traditional cell-free DNA screening. It is not interrogating all chromosome material. So that risk assessment is limited to the size of the deletions or duplications. There is still a residual risk. So it is not a definitive yes or no. A negative result simply means that the chance for that has been reduced but not eliminated. And again, because the positive predictive value is difficult to calculate due to the low prevalence of these copy number variants, this is not a recommended screening tool to be used on the general population. Anytime someone has cell-free DNA testing performed, is this just a reminder that this does not screen for open neural tube defects as historically maternal serum screening did in the second trimester. So maternal serum AFP only should still be offered after 15 weeks of pregnancy. And then something that I think is a reminder to always have in the back of your head when you're doing this, using this technology, is that results from this may represent chromosomal changes from the mom, from the placenta. It could represent changes from a vanished twin or even an ongoing twin that was unrecognized or not reported to the lab. And then it can also represent mosaicism, and that might be within the fetus itself. Okay, so going back to our birth defect etiologies chart, we've talked about the 10 to 15% of chromosomal etiologies. I now want to spend a little time talking about this 2 to 10% for a single gene disorder. So single gene disorders, we call those monogenic conditions. These fall into the category of autosomal recessive disorders, autosomal dominant disorders, X-linked disorders. And these, if you think about it from a chromosome perspective, our chromosomes contain our DNA, our packages of our information. And then, as I described before, within that chromosome, you have hundreds and hundreds of genes residing on each of these chromosomes. And so, as before we were talking, when you have a deletion or duplication of chromosome material, you're often missing a group of genes in that region. But for this next part of the talk, we're going to be focused on a single gene, one gene. We're going to be talking about 3 different inheritance patterns and some of the technology that's used to investigate genes associated with these various inheritance patterns. The first inheritance pattern is one that probably most of you are familiar with, which is the autosomal dominant inheritance pattern. That means that in order for an individual to be affected, only one of their genes has to be changed or have a variant in it. So, reminder that we have 2 copies of every chromosome. Therefore, we have 2 copies of every gene. So, for a dominant condition, only one of those genes needs to have a variation in order for a person to develop symptoms. Most of the time, we do see these disorders being inherited from an affected parent. However, there are many disorders that can be a result of a new mutation in the fetus, and therefore there would not be a family history of the disorder. Also, in a person affected with a dominant disorder, we know that each pregnancy has a 50% risk of inheriting that change. X-linked inheritance. This is when we often see mothers being carriers. So one of their X chromosomes has a change on it or a variant, but because moms have 2 X's, one of the X's kind of compensates for the other. However, if a carrier mother passes her affected X to a son, because males only have 1 X chromosome, that son would then be affected. So with X-linked inheritance, we say that carrier females have a 50% chance to have an affected son and a 50% chance to have a carrier daughter. So single gene cell-free DNA There is a company that allows for the utilization of a panel of genes that fall into these two categories. These are genetic disorders that have either autosomal dominant inheritance or X-linked inheritance. And almost all of these conditions have what we call a high new mutation rate, meaning it is unlikely for a parent to be affected because these genes have what we call hotspots. And genes with hotspots are usually our bigger genes. So I want you to think about Duchenne muscular dystrophy. That's one of the biggest genes we have in our body, the DMD gene. The bigger the gene, the more room for error. So these genes will often get new mutations. So there is a screening test called Vistara. This is offering from the Natera laboratory that looks for 25 autosomal dominant and X-linked conditions, as I mentioned before, most of which are going to be new mutations in the fetus. And that's an important point because if you recall, a mother who's affected, if we did cell-free DNA testing on her, then you would pick up the mom being affected and it would not be a reliable test for the fetus. So we need the mom to be unaffected in order to get information on the baby. So the sensitivity and specificity of this particular test is dependent on the gene that it's looking at. And there is, as I mentioned, an increased incidence of de novo or new mutations in this gene list. And there are some select conditions in this group that have third trimester ultrasound findings. Third trimester ultrasound findings are often associated with like skeletal dysplasias. Many of those we might not see until the late second trimester or early third trimester. Or we might just have some non-specific findings that aren't pointing us towards a chromosome condition, but we might be leaning more towards a single gene disorder. So why might we use this test? One reason could be due to advanced paternal age. So we all know here that for women, as women increase in age, their chances of having a child with a chromosome problem, an extra or missing chromosome, that chance is higher with advancing age. And however, with men, it's different. So with advancing paternal age, we think about the increased risk for DNA replication errors in these genes as a male gets older and goes through multiple replications of spermatogenesis. So replicating new sperm over a lifetime opens up the opportunity for there to be more areas for new mutations to occur. So that's one consideration. If I have a dad who is 45 or 50 years old and wants to do anything and everything, we always say ultrasound's our best tool for looking at these things, but we do have the availability of this screening test if they were interested. We also know that if there's a paternal family history of one of these conditions, then Vistara would also be have utility there because it doesn't matter if dad's affected because we're not looking at dad's DNA, we're taking the blood sample from the mother. And this can be helpful too because some of these conditions that are dominant, they have what we call variable expression. So not everyone who has the condition is going to present in the same way. Noonan syndrome is a good example of this. Noonan syndrome is a condition that we will oftentimes see a cystic hygroma for on ultrasound, or maybe even something more non-specific like just fluid around the baby's lungs. And there could be an affected parent who doesn't have any outward facing signs, maybe has never experienced any medical problems to prompt them to have a genetic workup, but they could themselves be affected because of the variability in some of these conditions. And then I mentioned before considerations here for late gestation ultrasound findings for patients who are not electing prenatal diagnosis. And as I mentioned before, the conditions on this particular panel are associated with things like the skeletal dysplasias or even the craniosynostosis, where you have premature fusion of the fontanelles in the brain. So moving into the case, this is a 34-week pregnancy that had ultrasound findings of a bell-shaped chest and extremely shortened long bones with multiple fractures. There is also stippling of the ribs, which told us that there was problems with ossification in the bone mineralization. So based on these findings, we knew that our high suspicion was for osteogenesis imperfecta. Because this patient was late to care and therefore late to be kind of diagnosed with these ultrasound findings, she did not want to pursue an amniocentesis for a skeletal dysplasia panel because the turnaround time would likely put her almost to delivery. She was really looking for something that could get her information a little bit more quickly. So we offered her this Vistara test that we knew was going to screen for those select skeletal dysplasias, also including the osteogenesis imperfectas. We then also offered her amnio, that where we would do a more comprehensive skeletal dysplasia panel. But because of the turnaround time, she was really hoping for some information ahead of delivery. And we did come back with a positive result with a likely pathogenic variant or change in a collagen gene. These collagen genes are the ones that are implicated in the OIs. There are 4 different osteogenesis imperfectas. This one was predicted to be the most severe, which we suspected based on there being in utero findings. So we were able to counsel this patient of the high likelihood of a neonatal demise, shortened lifespan associated with this diagnosis. So this was able to offer her some, you know, anticipatory guidance despite her being so close to delivery. So this non-invasive option was elected essentially based on turnaround time and her gestational age. And again, just take away from this, keeping in mind that when these skeletal dysplasias present themselves later in a gestation, it's sometimes you're bumping up against the clock, and this screening test in this case was a more appropriate given that we would have the information ahead of her delivery. And she was then, of course, referred over to the NICU for management and surveillance. So I will pause there and take any questions related to this case.
Okay, so again, I'm monitoring the chat for any questions or comments, and I will read them without identifying the source. And if we're not getting many questions, and I'm going to ask for our hub team, if you can please send some questions to me. Okay. Even though the non-invasive option is not diagnostic, management of pregnancy based on these positive findings. I'm not sure if.
Yeah.
Okay.
So that's a really good question. I really like that question because you have a positive screening result, but you also have ultrasound findings that are corroborating that positive screening result. So this did, affect how our maternal fetal medicine team was interacting with this patient and preparing this patient for delivery.
Okay.
Any other questions from any of our participants or hub team members? I'll take the opposite approach too, and say, Jessica, just to comment, if a patient has a positive finding, but then this test or this screening test comes back negative, it can give a false reassurance, I think. How do you deal with that? Because it's you have to be very careful, because sometimes patients might get the result before you're able to talk to them and they think everything's fine then. What are your...
Absolutely. I think that goes back to just the pre-test counseling. I think ordering of this type of technology is probably best done by a genetics provider or a maternal fetal medicine provider who's familiar with it, mainly because this is a very limited scope. There's only 25 conditions on here. So false reassurance is real. It's a real thing for these patients who get these negative results. if there's a skeletal dysplasia, this is not comprehensive. It's not looking at everything. So that pre-test counseling, I think, is really important to say, if this test is negative, that means we've ruled out these conditions, but we still have, X, Y, and Z. And our recommendation would be a skeletal dysplasia panel at birth.
Next question is, what will it take for a cell-free DNA to be considered diagnostic?
I'm not sure that that's an interesting question. By virtue of just thinking about a diagnostic test, diagnostic would mean you're getting a sample directly from the fetus. So whether that's skin cells or blood. So during a pregnancy, that's going to be quite hard to do, just because that is not passing through into the maternal bloodstream. You really only have trophoblastic cells that are in maternal blood that we know of at this point. So, unless we discover that there is a different type of cell or cell-free DNA that's coming directly from the fetal system, I'm not sure that this will ever hit the diagnostic benchmark. But I do think that the sensitivity and specificity of this type of technology is going to continue to get better. And I think we'll still be cautioning people, of course, that a screen positive result or a screen negative result, to Dr. Campbell's point, does not mean that there is a diagnosis, and it doesn't mean that we're ruling out a diagnosis either.
Jessica, I couldn't agree with you more. I don't think that this test, although it gets better and better, just like you said, I do not think it's diagnostic at all now. I mean, it gives us preliminary results that we can discuss with the patient, but it's still a screening test and not a diagnostic test. And people have to understand that.
Absolutely, DJ. I think that's exactly right. And I think it's hard for I mean, even when I talk with my students and, other colleagues, it's hard because a lot of times you hear people talking about this is a fetal screen. It's like, well, it might be a fetal material, but this is placental in origin. And we know the placenta and the baby do not always match.
There's a question that came into me about the counseling portion of this because of the complexity and maybe the parent anxiety or understanding how to communicate with the mother, like what is taken into consideration with how that is done.
So I will take that question.
Okay.
First of all, me and Barry and Eric, in my opinion, it is not the correct people to talk with the patients about this.
Okay.
I think someone with a master's degree in genetics should talk with them. And the way, like Jessica showed you how her little cartoon showed ABC in a gene and showed how it was a deletion and how it was a duplication. Their pictograms and the information they have, they really educate the patient about the issues. And and you're right, it's very complicated. Very complicated. And when I walk in every genetic counseling room after they've talked to them, the patients always say, "Oh, that was so good. I now understand." So I would just advocate for sending the patient with any issues to Jessica or a genetic counselor.
Yeah, I couldn't agree more. One of the things that I want to add to that too is from a counseling standpoint, I just have to say, for all of those participants on this call and beyond, talk to your partners, talk to the nurses. And this is one of the things that happens. Many offices, it's the nurses that are offering these screening tests. I think it's absolutely vital to make sure that the patients know what they're getting. It's not assessing all of the chromosomes. The basic NIPS is not. It's looking at trisomy 21, trisomy 18, trisomy 13, and extra sex chromosome abnormalities. And they need to understand that, because I think sometimes it's just painted as, oh, it's a great screening test. It looks at all the chromosomes, so it's good if it's low risk. And I don't like to say it's a negative test. It's a low risk test. That's really an important point. But I would say, if you've got you folks as nurses doing the counseling, make sure you're very careful in how you present it to patients. It's not going to rule everything out.
And positive results, especially the younger the patient is, a positive Down syndrome in a 20-year-old does not have the same predictive value that a positive Down syndrome result in a 40-year-old. And so it's be careful about saying your baby has Down syndrome, because the test says the baby is at risk for Down syndrome, but additional studies need to be done before we can say that. And we should never do a termination of pregnancy for say trisomy 13 that has a normal ultrasound without doing invasive testing or getting an amnio or a diagnostic test.
I was just pausing, and I will present this, but I don't know if there's feedback again from what Dr. Johnson said. So the next question was, how does a cell-free DNA result in a partial molar pregnancy? And I think after this question would be a good time to move to the next part of the presentation and then filter in more questions.
So
Mhm.
what is the question again, Rachel? I'm sorry.
How does a cell-free DNA result in a partial molar pregnancy?
So with our partial molar pregnancies, we expect there to be triploidy, so 69 chromosomes rather than 46, whether that's by 2 sperm on 1 egg, or the egg had a duplicated set of chromosomes and was fertilized by 1 sperm. So that's screened for in Natera's routine panorama screen. So because of the way that their technology works, they're the only lab currently that's able to screen for triploidy in a suspected partial molar pregnancy. Again, it's a screen, and I actually have myself scenario where I had a patient who screened negative, and then on microarray on products of conception after there was a fetal demise, the pregnancy did in fact have triploidy, or it was partial molar. So screening is still just screening, but that would be the way that would do it, would be through cell-free DNA. That particular lab can screen for that.
Why don't we go ahead and move on to the next, and then of course open up. So we close at 1:15, so make sure that we're monitoring our time.
So to close us out with the single gene conditions, we wanted to talk about recessive inheritance. And I think, I've had so many conversations with colleagues and our OBs that work here about, what is the carrier screening panel that should be offered, to everyone. And I want to say, full disclosure, I'm not talking about that here. I'm not going into, carrier screening panels. What I'm going to offer is one particular option when you have a patient who does not necessarily have an available partner. So, as a reminder, recessive inheritance is when a person is only going to be affected with a recessive condition when both copies of their gene has a change in it or a variation. And that's going to require one of those variants coming from a carrier mother and one of those variants coming from a carrier father. So we say that if we have two carrier parents, they have a 25% risk of having an affected child with whatever that recessive condition is. So there are two labs that offer single gene cell-free DNA screening for recessive conditions. One is called Billion to One. They have what they call a unity screen. And the other one is Natera, and this is a recent offering, and it's called their Fetal Focus. They both look at 4 autosomal recessive genes. Those first two, HBB and HBA, those correlate with the hemoglobinopathies, so sickle cell disease and any variants of hemoglobin related to that, as well as beta thalassemia and alpha thalassemia. And then you have CFTR, which is for cystic fibrosis, and then the SMN1 gene, which is for spinal muscular atrophy. These 4 genes are the genes that are recommended at minimum to be screened for by American College of Obstetrics and Gynecology. ACMG, Genetics and Genomics Society, they say that we should be looking at a bigger panel. But again, that's not what this talk is about. But I just want to say that these 4 genes are what the minimum is recommended by ACOG. So what these tests offer is that they do it in 2 steps. They get the maternal blood sample and they first screen the mother. So they're not looking at the baby at all. They're just doing routine carrier screening for these 4 conditions on mom. And if she is found to be a carrier or have a change in any one of these 4 conditions, they then reflex to do single gene cell-free DNA analysis on the fetus. So again, looking at placental DNA circulating in the maternal bloodstream. Because of the way this technology is set up, you do not need a paternal sample for the risk assessment. So some considerations in using this technology: if you have a patient who is a known carrier for cystic fibrosis, spinal muscular atrophy, or one of those hemoglobinopathies, and their partner is unavailable, this would be an option for them. If you have an at-risk couple, meaning both parents are known carriers for cystic fibrosis, for example, and their current pregnancy is at risk to have cystic fibrosis, then this technology would be an option if they decline a prenatal diagnosis. Again, prenatal diagnosis is our gold standard. We want our patients to know that, the recommended comprehensive diagnostic way is to go with an amniocentesis or a CVS. But we also know that not all patients are comfortable with that. So this would be an option for the at-risk couple who is not interested. The residual risk here for a negative result is a little bit difficult to interpret. They provide a positive predictive value for a positive result. So a lot of times it will look like, the chance is now a 9 out of 10. So a 90% chance that the fetus is affected. So it is, again, still in that increased risk or decreased risk result for those screen negative or screen positive. So an increased or a decreased risk. So the case that I have here is that mom came in and knew that she was a carrier for sickle cell disease. Her provider had done hemoglobin electrophoresis and picked up that she did, in fact, have hemoglobin S variant. The partner to the pregnancy was unavailable, and so she elected to do a cell-free DNA screen utilizing one of these labs. The first step, that carrier screening step, did confirm, of course, that she had the maternal sickle cell variant, and it then reflexed to the fetal testing. I apologize, the words are a little bit small here, but if you look at that first line under recommended follow-up, it says prenatal diagnosis via CVS or amnio is recommended for hemoglobin SC disease. That is telling us that they identified mom's sickle cell variant in the fetus, and then they are picking up what they believe to be a hemoglobin C variant, which on a hemoglobin electrophoresis would come up as a C variant in the hemoglobin pattern. So that second variant associated with the hemoglobin C was identified and predicted to be of paternal origin. Again, we do not have a partner sample. She was then offered prenatal diagnosis for confirmation of this. I'll also just call your attention to the report itself. You can see that she was not a carrier for alpha thalassemia, not a carrier for cystic fibrosis, and not a carrier for SMA. I am saying not a carrier to you because it says negative on the report. The way that I would say that to a patient is that your chance of being a carrier for alpha thalassemia, cystic fibrosis, and SMA has been greatly reduced. So we don't want to say never, again, because we don't know it at all when it comes to these sequence changes that are in these genes. So she elected for amniocentesis. The HBB gene is the gene that has changes in it that leads to sickle cell or hemoglobin C disease. So we did a targeted analysis of the HBB gene on the amniocentesis sample, and we did confirm that the mother's sickle cell variant and the paternal hemoglobin C variant were both identified in the fetus, which confirmed a diagnosis of hemoglobin SC disease or sickle C disease. Some takeaways from this case is that one limitation that would have been presented to this patient early on if she wanted prenatal diagnosis without a partner sample is that diagnostic labs request both parental samples for testing of autosomal recessive conditions. It does not mean that they will not do it. Some labs might have a hard stop on it, but there are labs that will say we'll still accept it. And that's because they have to confirm that the fetus is inheriting one copy from each parent. Sometimes if these copies are on the same chromosome, that's an unaffected fetus. So they do want both parental samples. So that would have been a limitation for this patient, given that her partner was unavailable. So the single gene cell-free DNA screening did allow for that carrier screening of the patient with the reflex testing of the fetus without the paternal sample. And then the detection of that paternal variant then allowed us to submit this report and say, hey, we think dad's got the hemoglobin C trait. We know mom's got the hemoglobin S trait. Can we now test the fetus? And that allowed for us to have a definitive answer. And the patient was then able to be counseled on hemoglobin SC disease, which was also important because in her mind, she was very concerned about sickle cell disease. And we were able to counsel her that while hemoglobin SC disease is similar, it often presents more mildly than sickle cell disease itself. So that was helpful to the patient. And that is it
Great.
in terms of my case. So I would welcome any questions related to that.
Yeah, please leave the slide up since we are recording and we don't want to see any participants. So just leave your slides up and let's continue with that. We actually have about a minute left. So I'm going to turn it over to Dr. Campbell to facilitate this last portion. And Dr. Campbell, I'll tell you if I have any questions.
Yeah, just let me know. I don't know that we have
Yeah.
enough time to get into much. I will say that I think that this is a great.
Oh, here's one.
Yeah.
Okay.
Are there any key differences in the various companies that offer cell-free DNA? I just lost the chat. You might finish it.
Which is your go-to?
I'm sorry?
Are there any key differences in the various companies that offer a cell-free DNA? Which is your go-to?
So I like to use the Unity screen just because of logistics. They only require one tube, one kit, whereas the Natera Fetal Focus is a little bit clunky right now in terms of a whole separate kit for it. So that's really the only reason. Their technology is different because Natera uses a single nucleotide polymorphism technology, which does give them Probably a little bit better of a detection, but overall, they are similarly reporting in terms of low or high risk. They offer the same number of conditions. So I have on here for the ease of this talk 4 conditions, but they do actually offer about 14. Yeah, so they're pretty much equal at this point. And again, I like the unity because of the logistical purposes.
Well, thank you very much, Rachel, and thank you, Jessica, for a great presentation. I think the take-home message from this, to me, is how this technology is ever changing and growing. I mean, gosh, we remember as it was starting out just to look at the 4 basic uh, chromosomes, the extra chromosomes, and now, gosh, what we can do with it. So it's phenomenal.